Hello everybody. In this lecture we'll be dealing with the management of root fractures. While you're here, do subscribe to this channel to receive regular updates. So let's go ahead with the lecture. Root fractures. These are those fractures which are present in the root itself and they do not extend onto the crown structure. A patient comes to your clinic. He gives you a history of fall or some kind of trauma. Now, when you clinically examine this patient, you discover that the involved tooth, the coronal portion of that, which is this portion, it is mobile or it is displaced. And in some cases, the crown structure may be temporarily discolored and there might be bleeding from the gingival sulcus. Now, all these clinical features would indicate that the tooth has suffered some kind of root fracture. Now, if you percuss it, you will discover it is tender to percussion. It shows a positive response. And if you conduct electric pulp test, you will mostly receive negative response, which would indicate a temporary or a permanent neural damage. Our next step is to take the radiograph. The first type of view which is recommended, it is the periapical view. Now this is very good for detecting fractures in the horizontal plane. As you can see it in the photograph, there is a horizontal fracture line running in the mid-root level. Now supposing after your periapical view, you are not satisfied because you're not able to detect the fracture properly. So what do? You go in for the occlusal view. Now, occlusal view is highly recommended for any fracture line that may be present in the oblique plane. As you can see it clearly here, this is an obliquely running fracture and here also. Now, after this, in case you want any additional information regarding the course of the fracture or the extent of the fracture line, then you can go in for OPG or orthopentograms. Now with the radiographs that we have taken at various angulations, we have been able to diagnose the fracture type and location. Our next step is to reposition the coronal fragment. Supposing your coronal fragment was displaced in the direction of this arrow which has been shown. What do? We use finger pressure to reposition it to its correct original position. Once we do that, we take another radiograph to check the position, whether it is correct or not. In case it is correct, we stabilize the tooth with a flexible splint for about 4 weeks. And we do that so that hard tissue callus gets formed. Now suppose our fracture line, it is say more cervically placed, something like this. Now in this situation, we have to stabilize for a longer period of time, say up to 4 months. Now once we have completed this procedure, our tooth has got stabilized with the splint, we send the patient back home. And we recall him after say 3 weeks, then 6 weeks and 3 months to check for any pulpal complications. Now in case complications develop, then we have to proceed in a different manner. So let's see what's that. What are the possible complications that can develop? Now there are certain signs and symptoms which indicate that the tooth is not responding to treatment and it has gone in for necrosis. Now what are those? Clinically, the most common symptom is that of pain. A patient comes back to you, he says he's having pain in that tooth. Or there is mobility of the coronal segment. Or there is extrusion of the coronal segment. Now all these symptoms would indicate that your tooth is not responding to treatment. Now another common sign is that during pulp testing, we continuously receive a negative response for a long period of time, you can say up to 3 months. Then radiographically, you can detect radiolucency in the area of the fracture. Now this would indicate that bone resorption has started taking place in this particular area. Now when a patient has developing all these signs and symptoms, how do we treat it? Treatment is very simple. All you have to do is make an access cavity, remove the pulp of the tooth coronal to the level of the fracture and then fill it up with gutta percha as I have shown it in the photograph. So you have to do your root canal filling only till the fracture line and not beyond. Now this type of treatment, it is pretty successful and it has shown good long-term prognosis, but it is effective only for middle one-third fractures and apical one-third fractures. I hope you're enjoying your lectures on tooth trauma. In the next lecture, we will deal with luxation injuries like concussion, subluxation, intrusion, extrusion, and avulsion. Also check out the videos on dental caries and occlusion. Do subscribe to this channel and share it with your friends. Thank you.